we're a very intimate group. This is a very intimate group. So what I'd like to propose is we make this an intimate session and not do the PowerPoint. Is that okay with everyone? And just have a nice conversation. So I'd just like to start by introducing our esteemed panelists. So we have Dr. Phil Rosenthal with us. He is an internationally renowned children's liver disease specialist. Dr. Rosenthal is the Director of Pediatric Hepatology, Director of Pediatric Clinical Research, Director of Pediatric Hepatology and Liver Transplant Research, and a Professor of Pediatrics and Surgery at the University of California, San Francisco. He is a board certified in pediatrics and pediatric gastroenterology and has a certificate of added qualification in transplant hepatology. Dr. Rosenthal completed his medical training at Downstate Medical Center and the Albert Einstein Medical Center in New York. He then completed a fellowship in pediatric gastroenterology at UCSF. He joined the UCSF faculty in 1995 after serving as professor of pediatrics at UC Los Angeles. His current research studies include several NIH-funded studies, including children, NASH, CRN, HBV, CRN, PALFSG, and IWITH, and several industry-sponsored hepatitis B and C research trials. Dr. Rosenthal is a prolific author and a recipient of a number of professional honors and awards and is committed to clinical service and research and education. He's also a member of our medical advisory board and also was the one who diagnosed my son. So that's Dr. Rosenthal for you. We also have two parents on our, we have Laura James Beckham on the far side. Dr. Laura James Beckham is a family physician with an OB and urgent care specialties. She is the mother of a 22-year-old named Brianna, who's here, 18-year-old Gavin, and the wife of Ed, who's here. Ta-da! All of whom are here at the symposium. Brianna was born in 1994 with ALGS. She has severe liver involvement and failure to thrive, significant nutritional issues, osteoporosis and fractures, vascular involvement, borderline renal and pancreatic involvement, and the foggy brain. Brianna received her liver transplant in September 2011 with a procedural complication that is starting to be recognized as occurring with higher frequency in children with vascular involvement. In February 2016, she underwent a fecal transplant for what is it? Yeah, I'm going to give. C. difficile. Okay. Okay, it's an infection. As a complication of her medications, Dr. James Beckham has shared this ongoing ALGS journey with her family for years, and she and her family are here to share their different perspectives and welcome you to approach any of them with your questions, and we'll learn more about that as we talk further. And then finally, we have Wendy Morrissey, is it Reimer, a Los Angeles native. Her journey with ALGS 7 years ago with her beautiful daughter Rainey was born. And one day Rainey was in the emergency surgery and had 60% of her small intestine removed. After extensive testing and multiple procedures, she was diagnosed with ALGS at 1 year old. At 5, she had a liver transplant. Rainey's parents have traveled all over the U.S. educating themselves about ALGS. So since you just joined us, we're going to since it's such an intimate group, we're just going to kind of skip the PowerPoint presentation, and it's available for those of you that want the PowerPoint. It'll be on your jump drives, and you can view it at home. But I think we have limited time, and we'll get so much more information out of our lovely panelists here and share information. So for those of you in the room, how many have had a child with a transplant? How many are considering a transplant or on transplant list, maybe?
Yeah, but it has come once in a while.
Okay. And what brings you to the session?
Well, we're not there yet. That's what the doctors keep telling us. My wife's in the bottom line for the transplant.
Okay.
And we figure we try to tackle
you're tag teaming. So,
Yeah.
so one's going to do the information before transplant.
Yeah,
and
then I
one-
was gonna do the after and take
Okay.
notes and talk about it some more,
Okay.
tonight.
Perfect, okay. So this is the first time at a symposium we have done one specifically on post-transplant issues. We now have a large enough population that have had transplant that we thought it was important to kind of address the issues post-transplant. So let me just start off with a question for Dr. Rosenthal. So, you know, liver transplant, of course, takes care of the liver disease portion, but what would you recommend in terms of following up with the other things that aren't necessarily liver-related for Alagille syndrome post-transplant?
Okay, well. Is it on? Okay. Can you hear me?
Yeah.
So from a liver standpoint, obviously, a new liver from somebody who doesn't have Alagille syndrome will correct the liver abnormality. Having said that, it's trading one set of circumstances for another because, as you know, livers that are transplanted need to be well taken care of. There aren't a lot of livers floating around, and we aren't quite at the point of being able to grow livers in a test tube or in the lab, and people are working on that. There's research going on with stem cells, and there's hepatocyte transplants. There's a lot of really exciting work being done, but none of that is prime time. So currently, the only ways you can get a new liver is either from a living related person or a deceased donor. And livers are matched by blood type and size, to make it simple. And after you're transplanted, obviously, you need to make sure that you don't get infected and you don't reject your new organ. Some of the exciting things in that regard, as long as we're talking about the liver, is the fact that some studies we're doing, we've taken people off their immunosuppression. So I have some patients that are 8.5 years now on absolutely no medicine following a liver transplant. So tolerance is a big, big field in transplantation, and I anticipate that in the future you'll hear more and more about that, because all the drugs that we need to use to keep the liver healthy, unfortunately, have side effects. And one of the biggie side effects is obviously effects on the kidney. And as you know, Alagille syndrome, some people can have significant kidney issues, and the last thing you want to do is make the kidneys worse. So after the liver transplant, to get back to the question in a roundabout way, it's really important that the other organs, which have not been transplanted, obviously, and still may be affected, are monitored. And I would think that's probably the answer to your question, is that monitoring is important. So if you had a cardiac issue, putting in a new liver is not going to fix your heart, or putting in a new liver is not going to fix your kidneys. And if you have vascular abnormalities in your brain, it's not going to fix those either. So you need to still be monitored by somebody who knows about what to expect.
So I'm really curious about the patients that are going off immunosuppressants. What are some of those? I think everyone in the room that has a child on immunosuppressants. So what are some of the indications for that?
Well, the first thing, if you're really interested, there was an article we wrote that's in the Journal of the American Medical Association, JAMA, about our trial where we took, the original trial was in children that had living-related liver transplants. Now, not always can that be the case for patients with Alagille syndrome, because very likely there might be a parent that also has Alagille's, and then obviously giving a liver from somebody who has Alagille's to somebody who has Alagille's would not be a good trade. Let's put it that way. So sometimes donors that want to get worked up, if they're related, may need to have even a liver biopsy to make sure that the liver is actually good to do for transplant. But in our immunosuppression withdrawal trial, what we did is we took living-related donors And the majority of those patients obviously had the leading reason why kids need liver transplants, which is biliary atresia. And we were able to very painstakingly, very, very slowly wean down their immunosuppression. Not everyone can get off immunosuppression. And unfortunately, at the moment, I can't tell you who will get off and who won't get off. I don't have a magic test that I could test them with to tell you that, you know, they will be tolerant or not. But we're working on that. And about 60% of the original batch of kids that we tried to get off immunosuppression have successfully gotten off. And like I said, some of them are 8.5 years on no immunosuppression. Some of them, one of them in particular, I know went to college all the way back in New York, and he's doing just fine. In fact, he's coming to visit me this month because he's out of school. So they can do just very, very well. And I think you will hear more and more about that. Some of the studies we're doing now include patients that were deceased donors, withdrawal of immunosuppression. So you'll have to stay tuned because the data isn't all there yet. But I think, especially kids who get transplanted, there's a very good likelihood that we'll figure something out and know whether or not they can become tolerant of their organ over time. You know, as kids grow, as opposed to adults, we don't necessarily increase their immunosuppression. So they outgrow the dose. So the big dose that they started out as a child, as they keep growing year after year with their transplant, we're not necessarily bumping up bigger and bigger doses. So that was one of the clues. The other clue that we knew was that when kids become adolescents, and this is the same for Alagille's or for any other disease, you know, kids think that they're invincible, and they become what's called non-compliant. They don't do what they're told and what they're supposed to do. And some kids who didn't take their medicines after their transplant actually got away with it. Unfortunately, many of them don't get away with it and get themselves into big time trouble. So I would not recommend, if any of your own children have had liver transplants, that you on your own just start weaning them off the meds. I don't think that's a wise thing to do at the moment, but be aware that minimization of immunosuppression is probably a good thing to do and something you probably should talk to your doctors about.
Thank you. For the, oh,
Can we ask questions?
absolutely.
Just to kind of follow up on that, or have additional questions, are you seeing that there's a certain age at transplant? Like the younger they are, the easier it is to take them off? And then once they become young adults, is there still a likelihood that we'll be able to wean them off? Or early, you know, in their early to mid-20s?
So the simple answer is
Just because we're webcasting, thank you.
So the simple answer is that probably the younger they are, the more likely they are to be tolerant, because if you're an adult and get transplanted, you're less likely to become tolerant. So I think if you're 20 and then try to take them off, some patients get away with it because that's in the group of non-compliant. So there are some patients that can get away with it. Adults, some of them can get away with it. Again, I don't have a test that I could predict who will do that and who won't. And therefore, I would say that it's not likely, unless it was under a research protocol, that one should go around trying that. Because, you know, these patients got lots of follow-up. Besides being compliant with getting laboratory studies, they also had to get protocol biopsies. So, you know, in routine world of things, people who are doing well with a liver transplant don't necessarily go in and have to go get a biopsy. But in a research protocol, we really need to know what's going on, because, you know, you don't want to do something harmful to somebody inadvertently. But it definitely is possible, and I would predict in 5 to 10 years that we probably will find the test that will tell us who can get away with it and who can't.
Through blood work? Or
Well,
what
that's
kind
the
of-
hope.
Okay. So you can tell whether or not somebody would go into rejection if they didn't take their medication.
Right. I mean, what we're trying to do is see if there's a signature, be it that from tissue, blood work, or whatever, that would predict who is likely to be able to get away with not taking meds. That's really the goal of what our research is about. But it's not a simple task.
I guess as a parent, then my thought is, well, what's the greater risk? To wait the 10 years in hopes that the test comes around? Or, because to me, the other risk is the kidneys. So, you know, now he's in college, we've talked about weaning him, maybe, or at least drop down once a day, but this is not the right time. You've got to be in a more stable day-to-day routine, so, because I'm hearing weekly labs at first and going the whole 9 yards again, like after transplant. But I still would hope that before 10 years from now, that he might be able to wean off so we're not looking at a kidney transplant.
So I have seen patients early in my career who were on high doses of immunosuppressants because that's all we had at the time, who like 10 to 20 years down the road needed kidney transplants. And that's why I said about the kidney, because I really think that these drugs are nephrotoxic. Having said that, I think we're smarter in being able to use the new drugs that we have in our armamentarium that are less nephrotoxic. And I think because they're more potent, we can minimize how much patients actually have to get because they do a better job. But you're right. I think if you were to take someone who got transplanted, say for Alagille's when they were 3 or 4 years old, 20 years puts them at 24. Could they have an issue? They very well might. And that's exactly one of the reasons why I think the government was willing to spend the bucks for our research project, because that's the nail on the head. It's, you're trading one set of circumstances for another. And the nice thing about my patients is they're on nothing. And in the world of transplantation also, if you're immunosuppressed, immunizations become an issue. Let's talk nitty-gritty things. So, I have lots of patients who've never gotten live vaccines. You go to Disneyland down the road over here. There was a whole big measles outbreak about a year ago because, people didn't get immunized. Well, our patients can't get immunized. So, one of the first things I did for my patients who are off meds, they got all their vaccines. They're fine. And especially, going to college and going away, it's nice to be able to say to them, listen, you're protected.
May I ask a question? Sure. What are the new drugs? And then for like the typical Prograf, what would you say was a large amount?
So some of the new drugs are things like sirolimus, everolimus, tacrolimus, in fact. Prograf is relatively new. In the old days, we had Imuran, and we had cyclosporin. That was my mainstay drug. And many of the patients that I took care of that were on cyclosporin, they wound up with not only a liver transplant, but unfortunately, some of them wound up with kidney transplants too. So that's what I meant by some of the newer drugs. Also, I think we can monitor drugs a lot better now. The ability to get a Prograf level, I can get it every day if I need it. When Prograf first came out, it had to be sent out. And if you go to a local lab, it still has to be sent out, But I think being able to really get a handle on those things, and there's other drugs, Cellcept, for example, mycophenolate mofetil is a great drug. I don't use Imuran anymore, in fact. We still use prednisone, prednisone has a lot of side effects. But, you know, transplantation has come a very long way. And I think in the future, we'll be able to take people's stem cells, and we won't even have to give them an organ. We'll take their own cells, genetically engineer whatever's wrong with it, and give it back to them. So to me, that's where where transplantation's going to go. And will it be? I was just at the transplant meetings in Boston last week, actually, and the question is, will you be able to use xenotransplants? Will they be able to humanize a pig liver or something like that? Because there still aren't enough organs to go around for everybody who needs it. So what are you going to do until we can figure out how to grow up from your stem cells a new liver? But it's very, very exciting. It's really neat stuff.
Well, and if you banked stem cells from an allogeneic kid, you're going to run into the same situation,
Yeah,
right?
except that you could take those cells and genetically fix them. That's what's going to happen. I mean, I can't tell you what week that's going to be, and I wouldn't hold my breath, but, I really think that the future of all this is going to be that we'll be able to really manipulate the genome, and, with pluripotent cells, maybe it won't even be stem cells from, cord blood, maybe it'll be, some cells in your skin. They'll take a skin biopsy and grow them up and transform them into liver cells. There's work going on like that.
Yes. Do we have any other questions around some of those issues? Yeah.
I'll get to your question in 1 second. I do have a buddy out in Boston, transplanted. He's a year younger than I am, but he was transplanted in 2009. And about 6 months ago, he was kind of hemming and hawing about being in a research study to be weaned off of an immunosuppressant. Eventually, he didn't qualify, so he was kind of bummed. But I know it seemed like something was going out there out there on the East Coast as far as those sort of research studies that you were mentioning for getting off that immunosuppression.
We have some questions.
He was always telling us, when you do the transplant, you change one disease for another. So
Sorry, and so Wendy and Laura, so would you mind describing what is it like to be post-transplant, and what is your day like? How many medications does your child take? What precautions do you need to take right now that they had a liver transplant?
Is this one on too? Yeah, it is. Well, Brianna had her transplant when she was 17, and there's a lot of medications you're on initially. She's only on Prograf related to the transplant, so she's not on a lot of medication. She's 22 now. She was on tons of medications when she first came out, so you have to have a schedule and you have to be organized. And depending on the age of your child, even the older child, you're probably doing it all and keeping track of everything. And you have to be dedicated. And I guess the main issues are, for us, is you have a teenager and you really don't want a teenager to decide to go into that denial, and I'm superwoman, there's not going to be anything wrong with me, damn it, and so I'm not going to take my medication. So that's a serious issue. I think for Brianna, she's fairly obsessive compulsive about taking her medications. She was a personality who did not want to have a liver transplant. She was going to make her liver last as long as possible. I was the one with the Lizzie Gets a New Liver booklet for her to read and going, oh my God, my kid's probably going to need a transplant. I'm not stupid. And she eventually had serious enough cirrhosis and little microencephalopathy going on and that sort of thing, that she finally went in and just said, okay, I've been on the list. She'd been listed a couple of times already by her physicians. And she came in and she was... she would rather die than continue living under the conditions. She got her transplant shortly thereafter. So she's been very dedicated to, this is my new liver, it's this wonderful liver, and she takes her medications on clockwork. She has a cell phone alarm that goes off. She carries medication with her, Prograf Extra, even if she thought she was going to get home. So the focus becomes, a lot on taking that medication, but there's actually less medication to us because we aren't having to do vitamin E, vitamin K, vitamin D. All those things are, quote, vitamins, but they're all medication. And it's all, vitamin E. She was taking 30 cc's, liquid E that tastes nasty. Lipitor. She had a lot of medicine. So to her, post-transplant meant, I took a whole bunch of stuff because I was immediately very immunosuppressed. So you're taking all the antivirals and all that, but they take you off of all of that. And then if you're doing okay, and then they wean you down off the prednisone, she's doing great, and she's only on a low dose of the tacrolimus or the Prograf. And so that portion of it for her has become a lot easier, and the liver was one of those things that for us looked like a miracle. She got this new liver, her skin turned normal color immediately. You see bile flowing out. Because they just have it draining out, and it's like, oh my God, she has bile draining. It's just, and she gained weight, and frankly, she was not menstruating yet. Don't tell her I told you that. But she was completely delayed in pubertal development, and post-transplant, she started her period. This freaked her out. 17. And but you do trade things. Now she's got this immune compromise to deal with. And medication has potential toxicities. So if I answered your question, but it's...
Wendy, do you have anything to add?
Well, Rainey is 2 years post-transplant. She, again, is only on Prograf and magnesium to offset the Prograf. So, but right as soon as we were transplanted, she was on lots of medications, and we literally had to chart out everything. It was a lot. But you immediately saw lots of differences, not only, her color, but she started to get muscle on her arms and legs, which she never had. Her distended stomach went in, her spleen that was hitting her down to her hip, that's usually protected by your rib cage, approximately 6 months was almost completely back to normal size and everything. She then also had confidence of, she was a lot more daring and everything before. She was we haven't hit a lot of bumps, but that's not, I've seen lots of people that have hit a lot of bumps. We are just lucky right now. And I think she's on a small amount of Prograf. She takes 1.5 milligrams in the morning and 2 milligrams at night. So I guess I'm not sure what the smallest amount is and the largest. So, but it was encouraging to get information that we could possibly even have a chance to get off it, because I did not want to get her to have a transplant. That was not the road I wanted to go down at all. And we tried for as long as we could to not go down that road, but we ended up having to. And for her, she had 60% of her small intestines taken at birth, so we had to have a full child's liver. So on the waiting list, that takes a lot longer, and I just,
And just to throw in our experience, I have a son that had a transplant in 2012, and he did go through rejection just shy of 2 years post-transplant. So now he's on his second immunosuppressant. So we get two separate immunosuppressants that we have to deal with. You had a question?
I did. Listening to everyone speak, I think it just left me. Shoot, sorry.
Oh, no. Maybe it'll come back. So, we talked a little bit about, those kind of risky behaviors and things like that that are kind of so much of an issue, especially going into adolescence. And, my son's 13, we're kind of starting to go into those, and we were talking about non-compliance in terms of meds, but there's also other risky behaviors. And I would love to hear from both Dr. Rosenthal and some of the other panelists about and other parents in the rooms about how to address some of those risky behaviors post-transplant and their long-term.
Before you move on, I
Yeah.
remember.
Yeah, it came to you. Okay.
So you said that the study, taking patients off their whatever anti-rejection medication they're using, that it started out with living family donors. Are those donors, are those transplants less likely to result in rejection than a deceased non-relative?
Yeah. So the answer is probably no. The deal is, the reason why we started with living-related donors is because almost all other organs that need to be transplanted have to be matched. So I'm sure you hear about bone marrow transplants. They have these big things where they want people to donate their blood so they can see what their HLA typing is. Kidneys have to be matched. Lung transplants have to be matched. Heart transplants, kidney transplants, livers, blood type and size. And to be honest, in a little kid, if you can even go against blood types and get away with it usually. So it's only the blood type and size of the liver that matters as far as transplantation goes. Since we were doing something that nobody knew what was going to be, it was sort of a compromise with the government, who's paying the bill, that we would start with living-related donors because they would be half HLA matched. If you're the parent of your child, half the genes from the child are from you, the other half are from the mother. So that's where it all started from. But having looked at deceased donor versus living-related donors, as far as the amount of rejection, problems down the road, things like that, we've never been able to really show a tremendous, significant difference. We did write a paper a bunch of years ago where the amount of steroid exposure in living-related transplants was slightly less than patients who had deceased donors, which would most likely translate into the fact that they got less steroids because they had less rejection. But we couldn't show, if you just looked at true biopsy-proven rejection episodes, we could never prove that. So that's why we started with that. Now we've actually gone on. Our new studies are with deceased donors. It's all comers. So based upon the ability to be able to take people off that are living related, we were able to expand that to deceased donors now. But I should caution you that it was only 60% of who we tried to get off that we were able to get off. And that's the caution, because we don't know what the mechanism is. We don't really understand why we can get away with doing this.
So right now, it's almost like flip of a coin.
Well, it's research. That's what it is.
Second question. You spoke about switching to a low-dose, high-potency anti-rejection medication. Why would that have any? Why would the impact be any different? Low-dose, high-potency versus high-dose, low-potency.
So when you take your meds, right? Prograf, you have to take how many times a day?
For my son, it's twice.
Yeah, that's what it is for almost
Okay.
everybody. Because what happens is, and what you do is you measure the trough level right before they get the next dose. Because what you're trying to do is maintain a level in the blood. So if you can keep a good level, and over time what we do is we lower the bar for what the level is. So if you're immediately post-transplant, your Prograf level may be 10 to 12 in that ballpark. Then if you get 6 months out, we may lower the bar again to 5 to 7 or 6 to 8, something in that ballpark. And then, you know, if you're 2, 3 years out, it may be 3 to 5. Okay? But in our minimization protocols, we're taking people, you know, when we wean them off, we're not going from twice a day to none. It may be once a day, maybe once every other day. It may be 3 times a week. In kids that we can't get off, that say drop out of the study, that doesn't mean that we put them back on twice a day. We might put them on once a day, okay? So that's kind of the things that we're learning about doing all of this stuff. But in general, if you were to ask me, what do you do with tacrolimus? It's twice a day, it's every 12 hours, and you want to maintain a blood level.
And last question. The older medications routinely cause damage to the kidneys. Has Prograf also been shown in studies to damage the liver?
To damage the liver?
I'm sorry, the
Or the
kidney.
yeah. So all calcineurin inhibitors is a class of drugs. Prograf, tacrolimus, which is Prograf, cyclosporin in particular. Those are in a certain class of drugs called calcineurin inhibitors, and those drugs are known to cause nephrotoxicity. And in fact, there were big problems with Prograf when it first came out because they really didn't know how to dose it very well. So instead of running, say, 10 to 12 or 5 to 7, they were running like 15. Believe me, that would cause nephrotoxicity.
Okay, thank you. So let's go back to the question about risky behaviors. No, those
You
were
need
great.
a family medicine doctor, not a pediatric hepatologist to talk about
We'll ask
risky
the parents about
behaviors.
the risky behaviors. Thank you, those were wonderful questions, thank you.
Oh,
Got you on the hot seat there.
yeah, I knew
Yeah.
I was gonna get suckered with that one.
Yeah.
Well, that's a lot of talking. I guess the first way to answer it is the way you answer it for everybody. And that is you need to sit down and talk. And the talking openly about sex, drugs, alcohol needs to happen when they're in school age. It's age appropriate at all times, but it should be happening early on. It should be something you're able to talk about and you're able to model, I suppose, if I'm going to put my doctor hat on. So that aside, then I'll put my mom hat back on, and I try to practice what I tell people to do. And so I think it's important to have those conversations at home, be open, be able to be open about talking about things. Hopefully, I think it's a lot easier if you have a relationship with your child that you can talk about these things. And if you don't, if it turns out you say, well, for some reason, whatever, personality, that you have friends, or you have teachers, or you have a village to help raise your kid, and you know that there's people you trust who your child can go to talk about these things, be it their physician, and that you can honor that privacy, or their teacher, or their, or a colleague of yours, or your uncle, or your the aunt, or whatever, that sort of thing. But it's part of our culture, and it's part of normal development to try things out. When you watch your toddlers, they all try things out, They try to step off the step, and if you have a 9-month-old that starts walking before anybody else, they're trying to drop off of things that they have no concept of the depth. And you have the same kinds of things happening in teenage years. Some people's frontal lobes are developed faster than others, and if they aren't developing very fast, then they can't. Their brain development doesn't develop fast enough to keep up with that risk-taking and being able to think about the consequences. And so then you have like a 9-month-old who's going to step off the step, and you're going to have to be more protective in intervention. I think being there is important. I think a lot of people forget about being there. They think, oh, my kid's past 8, and 8's such a wonderful golden years age, because 8 is, you know, they look like they're sailing along, they're doing great in school, and you go about your work, and then they hit 12, 13, and you forgot. You have to be there. And even if it's, you have to be there driving, and you can hear the conversation in the back of a car, they all think you're not there when you're driving. You find out what's really going on. If you get on Facebook, figure out how to be socially savvy. It's important to be there. It's just, you know, in a friendly way. It's important to be there, but you're not their friend either. You are the parent. So I guess those are my big sage advice. You know, risky behavior is scarier when you've got a child with a chronic illness. It's scarier. The immune compromise is going to make anything scarier. What for somebody who is immune compromised just makes them sick could kill our kids, you know, and so the discussions are more serious.
1-7, no risky behavior here.
Okay. We've heard a lot today about easy to say, hard to say, but foggy brain. And there's been some papers out about post-liver transplant executive functioning issues coming up, post-liver transplant. And some things coming up in discussions with other families, especially in our teen clinic. And I was just curious if Dr. Rosenthal, if that's something you've been seeing, if there's talk in the community about some issues regarding cognitive functioning post-liver transplant.
So I would say that probably any neurologic injury that occurred probably occurred before the transplant. If your liver is working well, then there's no reason why you should have any neurologic issues. It's pretty clear that when we look at patients who had chronic liver disease, and that's really what we're talking about here, that probably does affect your neurologic development. And, you know, part of our children's studies has been a lot of looking at quality of life and developmental issues. And the problem that is very, very difficult to tease out. Number one, it's very hard to find people who actually are expert in developmental issues. And I'm not just talking about the routine, you know, IQ test that somebody gets, but that actually does neurocognitive testing in patients with liver disease. There are very, very few people who actually can do that. And the bigger problem is that we don't have baseline. So you can't compare a kid that has liver disease with a kid that has heart disease, say, or has sickle cell anemia, or has, you know, thalassemia, or, you know, some other disease. I mean, it's comparing apples and oranges. Can you compare an Alagille patient to an alpha-1 antitrypsin patient, say, who also may have cholestasis? We're trying to do that, actually, within our children's studies, but again, it's really tough to do because many of the diseases are not identical. If you took a biliary atresia patient, which is, you know, where most of this work is done, you know, that's a pretty rapidly progressive disease. Alagille's is not quite as rapidly progressive as biliary atresia is. So it's hard to, you know, what's the comparison group? That's what I would say to you. The second is that there are definitely deficits. And, you know, was your child going to be the next Albert Einstein, and now they're only a pediatric hepatologist? I mean, I don't know the answer for you. I mean, it's really, really tough to know where the bar would have been if they didn't have this problem. And there's work going on, I would say to you. but, you know, how do you fix it? Okay, if you were supposed to be Albert Einstein and you're not, how do you make somebody into Albert Einstein? You can't. I mean, it's one of the issues in patients that get transplanted for a disease, you know, a urea cycle defect, where they can't handle protein, and they have an enzyme defect that doesn't allow them to handle protein. Those patients often get very high ammonia levels, which is what's associated with encephalopathy, you know, hepatic encephalopathy. And once they get transplanted, they never, ever again have high ammonia levels. But you know what? The neurologic injury that occurred when they did have that is lifelong. And we can't fix that. So, you know, the bigger issues would be what could we do early on? That's why it's hopeful that, you know, Lumina or whatever new drugs are going to come along. And the nice thing is that there finally are actually companies that are interested in Alagille syndrome. Because I can tell you, having done this a long time, you know, we still don't have a vitamin preparation for kids with liver disease. You know, it's borrowed from kids that have, you know, fat-soluble vitamin problems like cystic fibrosis patients. That's where the vitamins are coming from. That's not the right ratio of vitamins. But, you know, I think if we can get patients early, and that's why I'm really hopeful that, you know, genetic engineering, because, you know, could you do something in utero? If you really knew that you're going to have a child with Alagille syndrome, could you really early fix it so that it would not be a problem? I think that's where medicine's headed, but, you know, we're not there yet.
Okay, so here's the million-dollar question. How long does a liver transplant last? How long does the liver last?
That's an easy one.
We don't know.
Yeah. So if you take good care of it, that's the first thing. So the first thing I will tell you is that you know what the most important organ in your body is, right? Some of my patient families know this because I've told them this a million times. Most important organ in your body is the liver. And you know how I know that, right? How do you spell liver?
Oh, L-I-V-E-R.
Yeah, drop the R. What do you get? Can't live without your liver. And now what I tell my adolescent patients who are non-compliant, right? How do you spell liver? L-I-V-E-R, right? Drop the R and go backwards. What do you get? What's live backwards? It's E-V-I-L. Evil things will happen if you don't take good care of your liver. Okay? Ah, see, I knew I'd give you something you could take back. I bet you that's not in the other section. So, you know, I mean, it's really, really important. You know, we often transplant livers from older people into kids. Livers don't age. Now, whether or not we transfer any wisdom along with the liver is a whole other issue. But livers don't age, and livers regenerate.
Is that the only organ that doesn't age?
Well, there's two organs that regenerate in your body. The liver is one of them. You know what the other one is, but I'll see how smart you are. Skin. Exactly right. Those are the two. Often when I ask people that, they don't get it, so that's good. But yeah, I mean, it's skin and liver, and the same thing, you know, when you injure your skin, what happens? You wind up with a scar, right? What happens when you injure your liver? You wind up with a scar. When you get too much scar, what do we call that? Cirrhosis. It's the same deal. So livers can regenerate. The problem is that when you get too much scar in your liver, that's where you get problems with your liver. So many liver diseases, people actually don't get yellow, but they get what's called portal hypertension because they can't get blood flow into their liver. Alagille is different, though. You know, you don't have enough plumbing. That's really the issue.
So my last question is,
I don't think we ever got an answer to the million-dollar question.
I just said, doesn't age.
doesn't it?
So,
You didn't hear me?
yeah, I heard that, but I was like, I think
part
I was
about
still
the
thinking.
liver.
I think I was still thinking about, I think I was still thinking about,
The
The
liver
evil.
part, the liver part.
okay, so, oh, okay.
It doesn't-
I've heard, different, you know, different answers to that question.
Well, you only got right now the correct answer.
I thought another transplant was inevitable.
Absolutely not. Not if you take good care of it. Now, kidneys, it's a different story, okay? But kidneys don't regrow. So if you injure your kidney over time, you're going to get yourself into trouble. So many kids who get kidney transplants, as they get older, they outgrow their kidney, basically. Because if you ever took a look at a kid who got a kidney transplant, they usually take it from an adult. They try to give them as big a kidney as they can, because kidneys won't grow with the kid as the kid grows. When we do a liver transplant, we can give them a piece of somebody's liver. That liver piece will grow with the patient as the patient grows. And you know, if we take a part from a parent who happens to be kind of big, and we can't stuff it all into the belly, we can put mesh on the belly, and then in about a week's time, the liver is so smart it shrinks to the right size, and then it grows as the kid grows.
Okay. Any other questions? Yeah.
Does the donor, does his regenerate, like, the piece that he donates?
Yeah, so you don't grow back the piece that you cut out, but the other part will hypertrophy. So yeah, you get enough liver cells to function normally.
If you donate to someone, like, they need another donate, can you redonate?
No, because, you know, usually for a kid, we'll take the left lateral segment of the liver. The liver is actually divided into 8 segments. Though, you know, if you looked at a piece of liver, you wouldn't be able to see the segments. They're not labeled. But anatomically, there are. And you could, for an adult living-related donors, what they do is actually take the big right lobe, and that leaves the donor with a small piece of liver until it grows back up. But you don't grow back the right lobe. The left lobe grows bigger.
Okay.
Lana, did you have a question?
So many concerns over taking medications at the right time and all the non-compliance. Are there any research going into making some kind of a slow-releasing medication, patches and things like that?
Yeah, absolutely. There is once a day tacrolimus now. I don't know if you've heard about that. There is one a day. There's other delivery methods to give meds. You know, like insulin, they use pumps, for example, right? Instead of having to get a shot, you know, several times a day, you can have continuous infusion of insulin subcutaneously. So, yeah, there's lots of work going on like that, but I'm not really interested in getting more and more drugs. I'm actually interested in taking people off drugs.
Wonderful. Any other questions? Yeah.
My question, while directed at the 2 doctors, it's also for the other parents. I'd be curious to know your experience. Going into this surgery and knowing that my child would be on immunosuppressants, I expected, my understanding was that they would be more susceptible to illness, colds, whatever. But my experience in these 3 years has been that my child seems to get sick less often than the rest of us in the home. And I'm curious to know, do I misunderstand exactly what it's suppressing? Or is this unusual, or is this a common experience?
So it depends on how much immunosuppression you get. Obviously, there's a balance between rejection and infection when you use immunosuppression. You need to immunosuppress because otherwise there's a very strong likelihood early on that you could reject the organ, okay? So you don't become tolerant of your organ the day that it gets put in. So that's why we use immunosuppression in a large dose. The more immunosuppression means that you're taking your immune system, which fights off bugs that you get from being able to attack your new organ, but it's also unable to attack any bugs that should come along the way, which is why, you know, you shouldn't go to Disneyland where there's a measles epidemic if you're on heavy immunosuppression, because the chances of you getting measles is pretty high. So, you know, that's really the reason. If you're ill pre-transplant, you may get sick a lot, right? So the good thing is that probably your child is doing very well, and they're able to decrease the immunosuppression, and therefore your risks of getting infected are close, though maybe a little bit more than somebody in the general population. But it doesn't go away. As long as you're on immunosuppression, you're at risk. That's why if you get a fever and you have a central line in after the transplant, you know, that's like, you got to call the doctors right away. They got to do blood cultures. You got to get admitted for antibiotics.
So we,
And I think it's behooves us to remember that the immune system is also a very complex system. And cold virus is relatively benign. Measles is not. And when you go to Disneyland, your chance of coming in contact with the measles is probably the same as everybody else's. But when you get the infection, if you're immune suppressed, you're more likely to have a very serious process happening because you're immune compromised, whereas the person next to you will break out and be miserable, okay? So it's not just an exposure process, but it's an exposure plus how serious will the disease be, and then what are you being exposed to, which virus, which fungus. And when you're immune compromised, sometimes it's the funguses that would not be aggressive in a normal immune system become more of a problem in that type of immune suppression with these, you know, broad immunosuppressive drugs. And then you have an individual, probably you care a lot about this child, and so if you're like me, you're, okay, let's make sure you've washed your hands, and we cover, and when you're in a room with somebody who's coughing a lot, your child's more aware of staying away from their friends who are coughing all over the place. Usually, if you're post-transplant, you've educated your child not to share the drinks with their friends. They're not passing mononucleosis around with each other like all the rest of the kids. And so your other kids will come home with colds because they don't pay attention to those rules, and your transplanted person, my child, she's like, whoo, I used my Purell and I wiped down my desk and nobody's touching me, and how dare that person cough across the room, and so she doesn't get sick and the rest of us are sick.
yeah.
So keep that in mind.
Well, thank you. I want to thank everyone. We are out of time. Thank you to our panelists. We do have our expert Q&A going on downstairs, and then we will have our celebration dinner in the Crystal Ballroom starting at 6:30. So thank you all. If you have a moment to fill out the surveys, we really appreciate the feedback. So thank you. Thank you. Thanks. Appreciate your time. Thank you.